Welcome to Stakeholders' Perspectives on Return to Work for Workers with Compensable Upper Extremity Injuries. We're glad you're here. My name is Angie Hunt, Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be monitoring the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to WWDPI. We thank our program partners, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We'll collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all of these items when they are available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Susan Peters. Dr. Susan Peters is currently a postdoctoral fellow at the Harvard Center for Work, Health, and Well-Being. Her research spans both injury prevention and work disability prevention for workers in Australia, US, and Chile. She's currently working on projects focused on improving health, safety, and well-being of workers in the healthcare, construction, hospitality, and transportation industries. Dr. Peters is a mixed methods researcher who obtained her PhD from the University of Queensland, who also has over 15 years' experience as an occupational therapist working to help workers with musculoskeletal conditions to return to work and pre-injury activities. Her doctoral thesis explored the factors that influence return to work for workers with upper extremity diagnosis. And now I'll hand it over to Susan.
Thank you, Angie, and thank you to everyone who has joined us this afternoon. It's a beautiful day here in Boston. And thank you also to the Work, Wellness and Disability Prevention Institute for asking me to present this webinar today. So Angie gave you a little bit of an overview about my background, but I thought I would just touch on where I've been before I landed at the Harvard Center for Work, Health and Wellbeing. I received my degree in occupational therapy in 2001 and since then have worked solely in the fields of occupational rehabilitation and hand therapy. During my clinical practice, I managed a clinic in which about 90% of my clients were funded by workers' compensation as a result of occupational injury. And during this time, I was really compelled by the complex nature of return to work, and that not one single person really that walked through my doors had similar sort of experiences in their return to work and some of the challenges that they faced. So this led me to want to learn more, and I went back and completed my doctorate in health and rehab sciences at the University of Queensland and completed this in 2016. And for those of you who are interested, my thesis is actually available open access through the University of Queensland's open access repository, thesis repository, but most of the studies that I'm presenting today are also published. I'm currently a research fellow at the Harvard Center for Work, Health and Wellbeing, and I've been here since 2016. At the end of 2016, and I'm slowly getting used to the differences between Australia and the US in terms of workers' compensation and just living here in general. So some of the studies that I'm presenting today did form part of my thesis for my PhD, and so I'd like to just acknowledge my advisors who supported me through the process of completing my PhD, and also that I received funding from the Australian Hand Therapy Association and the Canadian Institute for Health Research through the Work Disability Prevention Strategic Training Program that ran out of the University of Toronto for a number of years. So through this webinar, we will explore the complex factors influencing return to work for non-traumatic upper extremity conditions through the lens of the various stakeholders involved in the return to work process, as well as research experts in the field. So the objectives of this webinar today are really to firstly understand the complex nature of return to work and return to work measurement. Secondly, using the biopsychosocial model, examine which factors different stakeholders think are most important in influencing the return to work process for workers with work-related upper extremity conditions. Discuss why different stakeholders have different perspectives and how this might impact on return to work process and return to work interventions. And to identify some of the consistent messages that we see through these studies and consider how these could be applied when we leave the webinar today. So the webinar today is split into 3 sections. First of all, I'll go through some background information about upper extremity injury and return to work and a couple of systematic reviews that have been completed in the field. Second section will focus on studies that I completed looking at the perspectives of return to work stakeholders and also experts in the field. And the third section will review the key findings and implications. So let's get started. Let's review some of the background. So we all know that for most people, our hands and upper extremities are important for us to perform necessary independent functional activity, such as our activities of daily living, cleaning ourselves, preparing meals for ourselves, but also we use them to communicate, engage with others and the environment, and the ability to perform key roles in the community and society, such as working in many occupations. Upper extremity pain and injury has both a high incidence and prevalence in the workforce. Systematic review evidence cites that the lifetime prevalence of upper extremity disorders can be as high as 53% in the general population. The most common being non-traumatic conditions, which cause a wide range of symptoms such as pain, numbness, tingling in the hands, stiffness, weakness. And these are conditions that we have heard a lot about. It's carpal tunnel syndrome, it's shoulder disorders such as rotator cuff tendinopathy, lateral epicondylalgia, or as it's commonly known, tennis elbow, and other nerve compression disorders and tendinitises and tendinopathies of the upper extremity. For those who experience injury, return to work is straightforward and simple for most. However, for some workers, it can be difficult and prolonged, having significant impacts on the injured worker and on others involved. Pain and injury to the upper extremity is a leading cause of work disability internationally. In Australia alone, upper extremity diagnosis contributed 23% of workers' comp musculoskeletal claims compared to the next highest MSK claim diagnoses of back pain at 22%. Non-traumatic conditions make up 60% of these claims, and frequently claims that require more than 1 week off work generally result in an average of 6 weeks of total work incapacity and cost over $8,000 per claim. Similarly, in other countries, we see similar findings, such as the US. Upper extremity conditions are also a leading cause of work disability and burden. The median time away from work for a worker with carpal tunnel syndrome in the upper extremity is 25 days, 3 times higher than other occupational musculoskeletal disorders, with a total cost exceeding $110 billion. We also know that for workers with upper extremity conditions who have at least 1 work absence, they are 26% more likely to have a second injury-related absence, compared to 18% of their colleagues with back pain. Despite advances in our knowledge of the causes of upper extremity conditions, the pathology of upper extremity conditions, and improved interventions such as endoscopic surgeries, minimally invasive surgeries, which are thought to be less traumatic on the tissues and theoretically allow quicker healing and hence an earlier return to function and work, disability and associated costs still appear to be increasing. Delays in returning to work and prolonged periods of work disability continue to persist for some workers beyond what we really expect. So I'd just like to touch on some of the definitions we use to define return to work. So return to work has been described as a process that encompasses a series of events, transitions and phases related to returning a worker to work. It's also been used to refer to the measurable final outcome of work status, such as working versus not working, whether it's a sustained return to work or whether they've had multiple return to works after work absences. And it's also been used to explain the capacity that the injured worker returns to work on, such as whether they return to work on alternate modified or transitional duty, whether they're returning to work on their normal or pre-injury duty, their normal hours or flexible work conditions. We also use the term quite frequently work disability, which is similar to return to work but different. Work disability is a disability associated with the absence from work, reduced productivity or functioning as a result of a health condition. It can be measured as prolonged work absence or a delay in return to work, and hence often we see these two terms being used interchangeably. However, we know that return to work is important and return to work is an important outcome, but when it comes to return to work, we often find it hard to define. In a Delphi study that I completed, that I'll talk a little bit more about later in the webinar, which consisted of 42 experts who had published 2 or more publications on return to work following upper extremity conditions, we asked them to try and define what return to work meant, or what return to work meant in terms of a delayed return to work. And these experts were from all over the world: Australia, Canada, US, Europe, Hong Kong, South Africa, and they were really divided in terms of how they defined return to work. 45% of experts said that it was not returning to pre-injury or similar work within the expected time frame. And 36% of the experts said that return to work was not returning to any time of work. What we can see here is the differences in the definitions are really about the type of work that the injured worker returns to. And this can also influence the outcomes that we see in terms of an injured worker theoretically should be able to return to lighter duty or modified duty before they potentially can return to work on normal duty, hence having different outcomes. We also asked these same experts whether they believed that time cutoffs should be used to delineate between a poorer and a better outcome, and if so, what that outcome should, what that time cutoff should be. 2/3 of the experts believe that time cutoffs should not be used, and the 1/3 of experts that believe that time cutoffs should be used were very much divided between time cutoffs spread between 2 weeks and 12 months. In a recent systematic review published by Lisa Newington of the UK, she explored the variability in the time to return to work following carpal tunnel release. And what she found was, in the outcomes reported in the studies that she included, the return to work outcome varied considerably depending on the type of work that the worker returned to or whether it was modified or pre-injury duty. Even though the modified and pre-injury duty had the same median time to return to work, we can see the wide variability across the studies she included, and the means were very different. So return to work is really hard to define because of a number of reasons. Return to work is multifactorial, it's very complex, it can depend on the context or the country in which the return to work statistics or the research is being completed. Return to work definitions also depend on the stakeholders' priorities and perspectives in the return to work process. In terms of a worker's definition of return to work is likely to be very different than an employer or an insurer's definition of return to work. Differences in return to work definitions can also result in a difference in outcomes. So this is also very important to consider when we're looking at the research or trying to understand the complex nature of return to work. In some of the studies I'm talking about today, I mentioned the biopsychosocial model. I'm not going to go into this in too much detail, except to say that the biopsychosocial model really refers to the concept that biological, psychological and social factors combine to play a significant role in human functioning. I really quite like the diagram that I've used here. It's the diagram that was put out by the World Health Organization back in 2000, which looks at the relationship between the biopsychosocial model and the ICF model. So what does the systematic review evidence tell us about the factors influencing return to work for workers with upper extremity injuries? When I set out to do my PhD, I did a huge scoping review looking at all the literature looking at return to work for workers with upper extremity injuries. And what I found was that most of the literature was surrounded around carpal tunnel and shoulder disorders. Des Mueller's completed a systematic review which was published in 2017 looking at the factors influencing return to work following shoulder disorders, and I completed a systematic review on carpal tunnel release. So they're the two reviews that I'm talking about today. What we find when we look across both of these systematic reviews was that there was only 3 factors that were found to be prognostic of return to work for both workers with carpal tunnel release and shoulder disorders, those being greater functional limitations, worse mental health state, and pre-operative work absence. A number of other factors were found to be in either one or the other of the systematic reviews. And what we can see here is that the factors in green on your screen are those related to social factors such as workplace factors and compensation related factors. And there was quite a few of those. There are only 3 biological factors, age, and 2 pain related factors. And what I thought was really interesting was that there was only 1 psychological factor that was found to be prognostic for return to work in the shoulder disorders systematic review, that being lower recovery expectations. In the systematic review that I completed, I also looked at the factors influencing earlier return to work of workers with carpal tunnel release, and far fewer of the studies actually looked at this. And the 3 factors that came out as being prognostic for an earlier return to work were lower pain anxiety, worker desired fewer days off work, and having a more sedentary or less physical job. So what's missing from the systematic review evidence? We found that few studies exist. In the review on carpal tunnel release, there was only 11 studies, and the review on shoulder disorders, there was only 8 studies. Of those 19 studies, many of them were low quality. Most of them were focused on individual or administrative factors in which they were using existing databases through a retrospective designed study. Few focused on workplace or psychological factors. Few focused on the mechanisms that support or facilitate return to work, which is really important when we're starting to consider return to work strategies or return to work interventions. And the reviews were limited to carpal tunnel and shoulder diagnoses. So for one of the next steps that I was planning to take after I completed the systematic review was to design a prospective cohort study exploring the predictive value of a number of these biopsychosocial factors on return to work outcomes. But after seeing the results of what I found in the systematic review, I felt like there was something missing. There was a number of factors that just weren't coming out or hadn't been studied previously. So I decided to take a step between the systematic review and the next phase of doing the cohort study and really ask those people that work with these injured workers every day, the stakeholders involved in the return to work process. I also consulted with research experts to see what their perspectives were as well. So what do I mean by stakeholders in the return to work process? I define stakeholder as anyone who can place a stake in it, anyone who stands to gain or lose through the return to work process or the return to work outcome. If we were all in the same room right now and we could turn to the person next to us, we're probably scattered from the US, Canada, different states in the US, different states in Canada, probably potentially other countries. And we probably can identify similar but also different stakeholders that might be involved in the return to work of injured workers. Some of the qualitative work that's been done by myself and Ella McEachern has found that stakeholders have differing priorities in the return to work process, and this drives decision making and some of the return to work processes and stakeholder actions that we see. So in saying that, before I get into the studies, we know that context is important. So it's also important for me to be able to frame the studies that I'm talking about in the Australian healthcare and compensation systems where I conducted my research. Australia has a complex patchwork of arrangements comprising of the following key elements. We have universal healthcare, which is supplemented by private insurance. We have mandatory state statutory no-fault workers' compensation, which provides income replacement, medical and rehabilitation reimbursement to healthcare providers and other providers, return to work assistance, and permanent impairment and fatality compensation. Workers also have the potential to claim for common law damages for pain, suffering, and loss in our system. The figure on the right-hand side of the screen is how a worker would navigate or walk their way through the system after they see the doctor and get a medical certificate to say that they have a work-related injury. The next gatekeeper is the insurer, who can either deny or accept a claim, and the worker has responsibilities throughout the process to really follow the directions of the insurer, to keep their medical certification up to date, for example, and to work their way through the system until they return to work on either light or normal duties. At some point in this process, the worker either recovers and the claim is closed, or they're assessed for a permanent impairment evaluation, at which time they're provided with some remuneration based on that. Their claim is closed, and if they have some ongoing impairment, they can be assessed for disability benefits. Okay, so leading into the second part of this webinar, I'm going to talk about 3 papers that have been published out of 2 studies. So I completed a cross-sectional survey of return to work stakeholders in Australia in 2013 and 2014, which the purpose of the survey was to determine stakeholders' perspectives on factors influencing return to work and also to explore any differences between the stakeholder groups. We used a web-based survey platform, but we also used hard copy surveys distributed at key stakeholder events to really target some of the insurer and employer representatives that may not have been forwarded the web-based survey. We used a snowball recruitment method by gatekeeper organisations, and people were eligible to complete the survey if they self-nominated themselves as having experience managing workers with upper extremity conditions. And these were really lumped into four categories: healthcare providers, employer representatives, insurer representatives, and lawyers either representing injured workers or workers' compensation insurers. The survey was divided into 3 sections. Demographic information was in the first section and some workplace information. The second section asked the respondents to rate 50 factors which were taken from the literature that were found to influence return to work. And they were provided with a preamble first about what types of non-traumatic upper extremity conditions, what constituted as that, and then they were asked to answer a question to rate the degree of influence they thought those factors had on a worker's ability to return to work. There was also a third section to the survey which included a case vignette, which I'm going to describe in a little bit more detail in just a moment. So there was 1,011 people who responded or completed sections 1 and 2 of the survey. They were mainly female, aged between 30 and 49 years, with over 10 years of experience. Most of them had managed more than 11 workers with upper extremity conditions per month. But the stakeholder groups were quite heterogeneous, with the healthcare providers really sort of skewing some of the results. There was more female healthcare providers and more healthcare providers that managed more than 11 workers per month. The other groups had fewer in those categories. So looking at the results of the survey, in this graph, what you can see are the factors that more than 75% of stakeholders either thought were very influential on return to work, or down the bottom of the graph, what you can see are the two factors that more than 75% of the stakeholders thought weren't as influential on return to work. Of the 50 factors that we included on the survey, 21 were found to be very to extremely influential on return to work, and only 2 were not as influential. The ones with the highest frequency are at the top, going to the lowest frequency as you move down the list. I'm not going to read the whole list to you, but the first few that are on the list are worker displays difficulty coping with the pain or injury, worker self-efficacy to return to work, workers' post-operative psychological status, supportive employer or supervisor, the employer's willingness to accommodate job modifications. And as you can see, as I'm reading this list, what we're seeing is a lot of psychological and social factors related to the workplace. Now, this becomes more obvious when we map these factors that more than 75% of stakeholders felt were very to extremely influential on the biopsychosocial model. What we can see as of those top factors was that 12 of those factors were social factors related to social support, working conditions, job accommodation related factors, and whether the worker had engaged with a lawyer. 4 of the biological factors were biological, 3 of those related to pain, and 1 related to overall function. And 5 of the factors were related to the psychological domain of the biopsychosocial model. Return to work out self-efficacy, recovery expectations, which are very similar, pre- and post-operative psychological status, and whether the worker had a mood disorder diagnosis, such as depression or anxiety. So in general, what we saw was that stakeholder groups agreed on about 2/3 of the factors that they believed influenced a worker's ability to return to work. What we did see was that there were differences between stakeholder groups on 19 of the 50 factors, but some of these were not modifiable factors, such as the socio-demographic factors, the most significant ones being age and gender, income, education, hand dominance. 3 of the factors were clinical related factors, in which healthcare providers nominated these as being more influential than the other stakeholder groups. And I think what's most interesting here are the social workplace related factors. There was just differences between the stakeholder groups, significant differences between the stakeholder groups for all the factors that you can see on the screen. Those including heavy lifting duties, repetitive duties, job control, job modification availability, supportiveness of colleagues, whether the worker had a suitable duties plan. That's an Australian specific plan, so that's a plan that's completed by the medical provider and other stakeholders to really determine what sort of plans are suitable, duties are suitable for a worker to return to, whether the worker had an in-house return to work coordinator involved. And this was very significant, and the difference here was that employers saw this as being really influential in the return to work process, whereas the other stakeholders didn't see it as being as influential in the return to work process. An in-house return to work coordinator's role is really to provide return to work coordination within an organisation. So that might be why we're seeing the difference in employers really valuing the support and the role of the return to work coordinator. We also saw differences between 3 of the compensation related, claiming workers' compensation and legal involvement was seen to be not as influential by the lawyers, and the doctor's recommendation for return to work. This was really the healthcare providers felt that this wasn't wasn't influential on return to work, whereas the other stakeholder groups saw it as being very to extremely influential. So what are the key takeaway messages from this study? Most of the factors that the stakeholders agreed on were related to the workplace or were psychological in nature, and the good news is that most of these are modifiable and amenable to intervention. There were differences between stakeholder groups for a number of the factors: demographic, clinical, workplace compensation system factors, but for none of the psychological factors. It's probably likely that the differences between the groups may reflect stakeholders' motivations and priorities in the return to work process, or factors just being more front of mind due to their occupational role and things that they see every day. We should also probably remember that having differences in opinions or discordant views are probably inevitable. If we were all in the same room, we're all from different backgrounds, we probably wouldn't all agree on the same factors that influence return to work either. And when the literature is so varied, there's really no consensus on at the moment on what are the factors that influence return to work. So the third part of the survey was a case vignette in which we provided a case scenario of a woman called Sally to the respondents, and there was 2 open-ended questions that asked them to identify barriers and also to identify strategies that could be implemented to address any of the barriers. We used a content analysis of the free text responses, and the responses were grouped according to the biopsychosocial model. So Sally had carpal tunnel. She had a whole bunch of things going on. She'd had heaps of treatments. She'd had lots of diagnostic tests, all of which were negative. She had gone on to have surgery. She told her medical providers that she didn't think she'd ever go back to work. She had an unhappy relationship with her co-workers, her supervisor. She'd consulted with a lawyer. And she'd just separated from her partner. So she had a whole range of things going on. So in this case scenario, there were 15 psychological barriers, 11 biological and 9 social barriers. And they were identified by all of the respondents that completed section 3 of the survey, which was 621 of the original 1,011. What we can see is that healthcare providers, lawyers, employers, insurers really nominated very similar barriers. No group nominated more barriers than the other, really, and none of the differences that we're seeing on this screen are significant. However, when we look at the specific barriers that they nominated, what we're seeing with the graph here are the 7 factors the 7 barriers that were rated the highest. And what we can that they were high pain levels, negative recovery expectations, personal relationship stress, work relationship stresses between the co-worker and the supervisor, lack of return to work planning, the fact that Sally sought legal advice, and the physical demands of her work. All of the there were significant differences between all of the stakeholder groups in how they responded to these barriers and how important they felt they were, except for the physical demands of work. So the interesting part of the case vignette, I think, was really when we asked them to identify what strategies they thought could actually help Sally. And the respondents could identify 4 biological strategies, 6 social strategies, and 6 psychological strategies. What we see when we map these to the biopsychosocial model is that healthcare providers tended to nominate more biologically focused strategies such as pain management, send Sally off for more diagnostic tests and reevaluate her, or do a functional capacity evaluation to determine her functional level, compared to the employers and insurers who nominated more social or workplace-based strategies such as job accommodations, return to work plans, case conferencing, and psychological strategies such as counselling and improving the quality of the communication between stakeholders. So these are the 6 top strategies that were nominated by the respondents. What we can see here is that there are 4 of these there were significant differences between the stakeholder groups, and it's pretty clear to see where the discrepancies lie. For pain management, healthcare providers felt that pain management was an important strategy for Sally, whereas the other stakeholder groups didn't. Adjustment to injury, we can see that insurers felt that this was an important strategy for Sally, whereas the other groups didn't. Psychological interventions other than counselling, healthcare providers thought were important for Sally, whereas the other groups didn't. So the key takeaway messages from the case vignette are that different stakeholder groups perceive similar barriers, but they recommended different strategies. Stakeholder disciplines and priorities and what they do or see every day are again likely to drive which strategies they perceive will be most successful, but don't need to be dismissed as being important strategies for facilitating return to work. Stakeholders perceive that the quality and frequency of their communication between themselves and return to work planning as being 2 of the most important strategies. However, in reality, we don't always see this happen. However, this does support the importance of having clearly defined supportive organisational policies and procedures and workers' compensation processes to really help support stakeholder communication and return to work planning. This also reinforces a multidisciplinary collaborative approach to managing return to work to get all the different perspectives from the different stakeholders involved. So the last study that I want to briefly touch on is a Delphi study that we completed asking experts their opinions on both barriers and facilitators to return to work. And we completed this through a 3-round Delphi study in which the first round we had open-ended questions on facilitators and barriers to return to work. They rated these on a Likert scale. And in the 3rd round, they indicated whether the dichotomized Likert scale, so the same dichotomization that we used for the stakeholder survey, where we just split them into not at all to somewhat influential and very to extremely influential into the other category, they indicated whether they agreed yes or no they warrant further research in a prognostic predictive cohort study. We had an a priori consensus definition, of which a strong consensus was classified as greater than 85%, and moderate consensus was classified as 60 to 84% consensus. So what we saw was that experts nominated far more barriers in round 1, but by the time we got to round 3, it was whittled down to just 6 barriers that more than 85% of the experts believed were barriers to return to work. They identified a number of facilitators, but when we got to round 3, what we saw was that there was far more facilitators to return to work that they agreed upon than the barriers. The items highlighted in red are factors that find themselves in both lists. So heavy physical job demands and the inverse of this, less physical job demands, for example, find themselves in the facilitators list. So some of the key takeaway messages from the Delphi study were that experts focused on facilitating factors that promote successful early return to work and can be used as strategies for return to work and in return to work interventions. Some of the factors have bidirectional effects, and we found that really interesting, in that maybe these are the factors that we can really push the needle on, in that if we can provide interventions to, for example, enhance supervisor support, this might really push the needle on being able to see more successful return to work outcomes. So what are the key findings and implications from all of, when we draw all the findings of these studies together? So were there any factors that were consistent between the studies for poor return to work outcomes? So when looking at the systematic reviews that were completed, the survey of stakeholders in the Delphi study, we found that 2 of the factors found themselves in all 3 lists, having more than 2 musculoskeletal pain sites and lack of job accommodation or alternate duty availability on a worker's return to work. The other factors, recovery expectations, poor mental health state, heavier work duties, lack of supportive organisational policies, procedures, low job control, lack of supportive co-worker relationships and litigation, found themselves in either one of the studies or the other. There are also a number of factors that were consistent between studies for better return to work outcomes, including high return to work or recovery expectations, high pain coping or having a lack of fear avoidance to pain, having high job satisfaction, having the ability to easily modify the job or options for alternate duties and return to work, returning to meaningful duties, having less physical work duties, and having supportive organisational policies and procedures in place. So what are the implications from these studies? When we're considering evaluation of return to work barriers and facilitators, what this really reinforces is that return to work is very complex, it's multifactorial, and it needs to be considered within its context. In saying that, we can consider barriers and facilitators to return to work as interlinked systems. Communication between stakeholders about potential barriers to return to work was identified as something that facilitates return to work and also as a strategy in the case vignette that we looked at. This also poses the question about whether there's a role for early identification for workers at high risk of long periods of working capacity and long-term work disability, which has the potential for us to direct targeted interventions to those who need it most. This also supports the findings from these studies, also support some of the qualitative work that myself and others have done, which really focus on we need to have a worker-centric paradigm shift in terms of having the worker involved in goal setting and decision making as one of the key players in return to work planning and communication, which we heard were 2 key strategies that could help to promote return to work, which really helps with their buy-in to drive their own return to work. The studies that I completed also really set the stage for future research on examining prognostic factors for return to work outcomes. In terms of return to work intervention planning, the management of barriers and development of return to work strategies really need to be considered as 3 interlinking systems of the biological, the psychological, and the social. We also need to consider that these systems operate on an individual worker and on a systems level encompassing the healthcare and the insurance systems in which they operate. This means that if we have interlinked systems, potentially we should have more integrated solutions. Developing targeted approaches based on early evaluation of the barriers to return to work and building on the facilitators to return to work to support return to work process really require a multidisciplinary collaborative approach across all domains. It requires joint goal setting, including the worker and other key return to work stakeholders. And as we heard, communication is really key. This also has implications for workers' compensation policies and procedures in terms of the types of programs and interventions funded, and the return to work procedures and processes that really help to facilitate stakeholder communication and return to work planning at early stages in the recovery. It also has implications for return to work policies for organisations. What we saw as being one of, as both a barrier to return to work as well as a facilitator, is that a lack of organisational policies and procedures resulted in poorer return to work outcomes, whereas more supportive organisational policies and procedures result in better return to work outcomes. So this also sets the stage for future research and the testing of return to work interventions. So I'd like to open up the floor now for any questions.
Great. To our audience, if you have any questions at this time, please enter them into the question panel on the GoToWebinar panel, and we'll read those out loud. Some questions that came in at the beginning of the presentation. What were the demographics of the different types of workers that you worked with? Construction, office, that suffered from upper extremity issues?
In my practice?
Yes.
I'm assuming? Okay. They were across a wide range of industries. Where my practice was based, we were very close to the Air Force and the Army base, so I saw people from the military. We also had a lot of people from construction and food processing, so we had a lot of industry around near us, as well as poultry and an abattoir processing facility. We also saw a number of workers that were office workers as well. So our clinic was based in the capital city in Queensland. So we saw a lot of office workers that had upper extremity conditions, ranging from carpal tunnel to even neck pain, which I haven't really talked about today. I've really differentiated between neck and upper extremity.
Okay.
A wide range.
A wide range. And a follow-up question to that would be, what kind of industries were representative in your stakeholder survey? Were they the same area?
In terms of the insurers, so the way that our insurance system works in a number of the states is that we have state insurance, so they cover all industries. In some of the states, we do have, it's legislated at a state level, but there are private workers' compensation insurers, but again, they don't tend to focus on one industry or another. In terms of the employers, they were across a wide range of industries, but we included that as an open text field for those people to self-nominate, to write into there. So we got a wide representation, but we don't know specifically from the employers how many of them were from industry.
Okay. Mm-hmm. In the systematic review evidence, how do you evaluate lower recovery expectations? Was it advice from the medical professional or perception of the patient, or both?
Good question. So lower recovery expectations was often a questionnaire that was completed by the worker themselves about what they saw their recovery to be. And generally the recovery expectations were in relation to two things. Do they think that they're going to recover functionally? And do they think that they're going to recover sufficiently enough to be able to return to work?
Okay. And then one last question from the audience. Can we receive a link to your thesis? And we can include this in the follow-up messages to our audience as well.
It's on the screen.
It's right there.
Right down the bottom. So I think when the slides are distributed to everyone, this has got all my details on there. Please connect with me. Feel free to download my thesis. And all of my publications have links through my LinkedIn and ResearchGate profiles as well.
Great. And I think that's all the questions for now. Dr. Peters, is there anything you'd like to add following your presentation?
No, I have nothing further to add. If anyone has any further questions or would like to just email me, that is totally fine as well. I would appreciate to hear from you.